So I'm going to pick up the presentation this afternoon by looking at some evidence as to what was known about hepatitis and in its various forms and HIV, HTLV3. There are numerous references in materials, medical records and the like, in particular to hepatitis through the 70s. So I'm just going to pick a selection of documents to try and give a flavour of what we understand. But it's clear that there were risks of hepatitis was well known to clinicians at Lord Mayor Treloar College. If we start by looking at TREL 40382. This is a letter from 1969, 5th of May 1969. It's from Dr. Rainsford, described at the bottom as a research fellow in haemophilia, to a Dr. Kelly. It looks like it's to a GP. And it refers in the first paragraph to a boy with severe haemophilia who had been transfused on numerous occasions. And then says this: "You will realise, therefore, that his present condition is almost certainly due to his transfusion with plasma, and that he is suffering from homologous serum jaundice and not infective epidemic hepatitis. The reason I'm writing to you about the diagnosis is that the public health authorities are under the impression that he might be suffering from infective hepatitis. I thought this information might be of some value to you." And then in the second paragraph, this: "Furthermore, this Haemophilia Research Centre is a branch of the Medical Research Haemophilia Centre at Oxford, which, in agreement with other haemophilia centres, is now conducting a nationwide survey into the incidence and cause of homologous serum jaundice." And then you'll see the GP is asked to complete an enclosed form and answer various questions. Reference there to essentially a distinction between what we would call hepatitis B and hepatitis A, but as a result of transfusion with plasma, a boy identified as suffering from homologous serum jaundice, and then we can see the participation of the then research centre at Lord Mayor Treloar Hospital in this nationwide survey into homologous serum jaundice.
We wouldn't necessarily call homologous serum jaundice B, would we?
Well, not necessarily. It would be...
It's a mixture of whatever is causing jaundice, which may be not A nor B.
Yes, so it could be non-A, non-B. It's a distinction, as it were, on the one hand, between something caused through blood transfusion and hepatitis A.
Absolutely. So it's either in the serum or it's elsewhere.
Yes. And then we've obviously heard evidence about the outbreak of hepatitis in what seems to have been probably 1974. It may have been that there was a subsequent outbreak again in 1975. If we look at NHBT 0107241, this is a report from Dr. Rainsford, again self-described as a research fellow in haemophilia, dated January 1975, and it's a report into the summer term of 74 and the autumn term of 74. We looked at bits of the document for different purposes on Monday. If we go to the bottom of page 2, we can pick this up with the heading hepatitis at the bottom of the page. 2 boys with inhibitors, and then they're given case numbers, and 8 of the haemophiliacs, again given case numbers, developed hepatitis during the autumn term, so that would make it autumn term 74. With the exception of 69, 97 and 45, all cases were extremely mild, icterus being absent, and bilirubin levels were only very slightly raised above 1 mg. All, however, had some symptoms. The remaining 3 cases, 69, 97 and 45, were more severely affected. All 3 boys were jaundiced with significantly raised bilirubin levels. All 10 boys had markedly raised SGPT and SGOT levels. One thing common to all cases was a batch of haemophil with which they were treated. Furthermore, case 69 had received no other replacement therapy with the exception of this batch of haemophil. This outbreak is being further investigated by the Public Health Laboratory Service in conjunction with Dr. Peter Kirk, who has spent a great deal of time in trouble with these investigations. It is hoped that a full report concerning this outbreak will eventually be published. No boy at the school, other than those suffering from coagulation disorders, had suffered from jaundice. So that's one account of what may well have been the same outbreak that Nick Sainsbury told us about on Tuesday.
Well, it may be the outbreak, might it, that Dr. Krusk reported on?
I'm sorry?
Might it be the outbreak which Dr. Krusk, in due course, reported on?
That's a separate one, I think. So Dr. Krusk reported upon an outbreak in Bournemouth. But he also, so Dr. Kirk and Dr. Krusk together certainly, I think, investigated this. And there are references to it in various UK HCDO minutes.
Yes.
It's part of what was reported on. Dr. Krusk also reported on, I think, some other instances. And then we can pick up some other references to hepatitis in 1974, probably to the same outbreak. TREL 5027_035. So this is December 75. It's Dr. McCarty, described there by reference to the Haemophilia Centre at the bottom of the page, writing to a consultant haematologist at the Princess Alexandra Hospital in Harlow, Essex, and referring to a boy transfused with a batch of haemophil, and the batch numbers they're given, while at school at Lord Mayor Treloar College. It's been found that this batch was infected with what was almost certainly B hepatitis virus, and several of the other boys who received the same batch have become jaundiced, though none of them severely. And we can see, if we go to TREL 40142_049, an almost identical letter being sent to Dr. Ritzer at Oxford in relation to two boys, presumably under the care of the Oxford Haemophilia Centre as a home haemophilia centre, infected with the same batch. There is then some further correspondence about it, and there appears at some stage to have been a lack of clarity as to whether it was hepatitis A or some form of serum hepatitis. If we look at HHFT 40931_001, we can see here that Dr. Holgate, a principal medical officer within the Department of Health and Social Security, wrote on the 23rd of December 1974 to Dr. Rainsford at Treloar's, "Thank you for the detailed information regarding what appears to be hepatitis A developing after haemophil," and then the same batch number 591V081A1. Some of these were, I believe, notified earlier, and according to Dr. Krusk, there's been a single case to batch 13A1. It's of great relief that no cases are really severe, but I do hope now that the virus of hepatitis A has been claimed isolated, we might get a test for it in blood products so as to hope to avoid such situations. Whether that's just a misunderstanding and he's meant to say hepatitis B is unclear, because there doesn't appear to be any doubt about the nature of the hepatitis, that it was not hepatitis A. But in any event,
in due course, you might be able to tell me when it was that there was any form of test for hepatitis A, which I think A itself had been identified or isolated in 1973.
yes.
I had assumed that a test was then available, but it might not have been.
I don't know, I'm afraid, without checking. There's a further letter which talks about whether it could be hepatitis A or B from Dr. Maycock. So if we go to DHSC 010018_107, this is the 5th of March 1975. It's addressed to Dr. Smith at the Wessex Regional Transfusion Centre, and the signature's been redacted, but it's from Dr. Maycock. And it says, "Thank you for a clutch of reports." So it's headed post-transfusion hepatitis. So the title is obviously some significance. Thank you for a clutch of reports of cases of hepatitis at Lord Mayor Treloar's school. It is extremely difficult to decide what forms of hepatitis these children had. I suppose that one can conclude that those with antibody, and then there's a list of names that obviously we've redacted, may have had clinical or subclinical hepatitis B on an earlier occasion, as it seems unlikely that the event reported was hepatitis B, but this may be a wrong conclusion. The 3 cases, and then 3 identified, negative for antigen and antibody may, I suppose, be either hepatitis A or B. Of the 2 cases with short incubation periods, one has obviously been exposed to hepatitis B antigen at some time, and then it's suggested that the other may be hepatitis A. And then there's a follow-up the following month, April 75, from Dr. Maycock, DHSC 013018_174. It's addressed to Dr. Vaughan, post-transfusion hepatitis. I attach copies of reports of icteric and anicteric hepatitis following the use of blood or blood products. I have divided these reports into the following categories. The first is probable, don't need to look at that for present purposes. The second category is possible or doubtful. And then the third category relates specifically to Lord Mayor Treloar's school. There are 17 patients in this group. Almost all were mild cases and transfused on many occasions over long periods. Some were diagnosed on transaminase levels alone. In some instances, the incubation periods are not in the usually accepted range for hepatitis B. Hepatitis A may therefore have occurred. I've divided them into 2 groups on the basis of antigen and antibody tests on the patients. And then we can see there's then a list of names we've redacted and reference to one being given only haemophil. And then over the page, those who were, a further list in his second category. And then the rest of the letter is concerned not with Treloar's. And we can see the author is Dr. Maycock, and it's dated the 7th of April 1975. So we can see the outbreak, whatever its precise classification, has been reported to and is being discussed within the Department of Health in spring of 1975. There's then, I think, one further letter, DHSC 010018_182. Again, from Dr. Maycock to Dr. Smith at the Wessex Regional Transfusion Centre, so the centre local to Treloar's, 16th of May 1975, post-transfusion hepatitis. Thank you for the following reports. And then obviously the names are redacted, but the first, which I agree, is probably a case of post-transfusion hepatitis. The second name, this is probably also a case of hepatitis B. And then the third name says, this seems to be a case of hepatitis probably attributable to factor IX concentrate. So it's clear that both at Treloar specifically and within the Wessex, or the area, the catchment area of the Wessex Blood Transfusion Centre, from the autumn of 1974 through into the spring of 1975, there was particular concern about this outbreak of hepatitis and these cases of hepatitis. What doesn't appear in these exchanges is any consideration of what the medical literature by this time, as we've seen previously, was identifying as neither A nor B, but some other form of hepatitis. I referred yesterday to the multiple UK HCDO meetings that were attended by clinicians from Lord Mayor Treloar's college or the haemophilia centre there. And I won't go back over those, but risks of hepatitis from blood products were the subject of discussion at a number of the haemophilia centre directors' meetings in the first half of the 1970s. And in particular, Dr. Kirk and on occasions also Dr. Rainsford are recorded in the minutes as discussing aspects of their research. And Dr. Kirk had a particular involvement in hepatitis research and the work of the Hepatitis Working Party, which we'll look at when we look at the issue of research tomorrow. And again, throughout the second half of the 1970s into the early 1980s, there is almost always a Treloar's clinician present at the Haemophilia Centre directors' meetings when issues relating to hepatitis are being discussed. As we've also seen from some of the records that we've looked at during the course of oral evidence this week, pupils were being assessed and tested for serum hepatitis in the course of the 1970s and early 80s. And we've seen also examples of the stamp hepatitis risk on medical records. Then if we look, please, at TREL 5070_056, this is a letter 20th of January 1976. In form, it's a questionnaire sent to Dr. Kirk, so Dr. Peter Kirk, from a Dr. Hamblin, a consultant pathologist in the Department of Pathology in Bournemouth, the Royal Victoria Hospital. But it's the answers that are of interest, so the answers presumably completed by or on behalf of Dr. Kirk. So there's a question about cirrhosis in questions 1 and 2. 2 says, are there any features suggesting primary biliary cirrhosis? No, except raised alkaline phosphatase. Question 3, does your patient have any other liver disease? Possibly, please see below. And then if we go further down the page, what other diagnosis has been established in your patient? Severe haemophilia. And then comments. So it refers to he had an icteric illness in January 1976, and then it gives details of liver function test results. It goes on to say he's negative for hepatitis B. His blood picture suggested glandular fever, but EB virus studies were negative, as was examination of his, I think that might be urine, looks like. I'm not quite sure. For CMV and EM of feces for virus particles. And then this presumptive diagnosis, therefore, non-B hepatitis, probably associated with the transfusion of cryobilin. And then in brackets, he is not our only case of non-B hepatitis of short incubation after receiving concentrates.
Yes, I think you must be right that it's urine, because it talks about the examination of the feces at the end of the line.
Yes, it does. Yes, it probably is. The signature overwrites it, which is why it was slightly difficult to read. But in any event, the key is really those last 2 lines.
Yes.
A presumptive diagnosis of non-B hepatitis, and the association is with the transfusion of cryobilin, and we learned that this isn't the only case of non-B hepatitis following transfusion with concentrates. So that's 1976. We looked earlier in the week, I won't go back to it, but in 1978 at a report from a Spaywood representative of a meeting with Dr. Arenstam, in which Dr. Arenstam talked about hepatitis as strictly a function of the number of doses given, but also referred, as you'll recall, to 48 of his present patients at Lord Mayor Treloar's having hepatitis, and referring to it frequently occurring. And then we can see 2 letters from Dr. Painter, who, as we heard, was based at Lord Mayor Treloar College or at the centre for a year or so. So 2 letters from 1978. Shomik, the first is TREL 30100_096. Or I may have written that down wrongly. Is that not coming up? I might have put an extra 0 in. TREL 4 zeros. It's the problem with handwriting things and not being able to read my own handwriting. I don't have a hard copy to check either.
Well, the first set of figures is always seven digits, so it would have to be 4 zeros.
That's it, thank you. So a letter of the 30th of January 1978 from Dr. Painter to Dr. Goldman at the Royal Free Hospital. Again, it's about an individual, but it provides a snapshot of what was known at the time. Second paragraph, as regards his abnormal liver function tests, we are finding that this is a very common problem with our 55 haemophiliacs at the college, in as much as probably half of them have SGOTs, AST, of 2 to even 3 times the normal limit. The significance of this is not readily apparent, and we are currently looking into this matter with some urgency. We have some boys who become jaundiced, and in these cases their enzymes increase dramatically, usually to at least 10 times the normal limit. And then there's a reference in the last paragraph, in addition to LFTs, doing a wide range of other tests, including terminally full blood counts. And then he encloses a detailed list of the particular patient's liver function tests over the previous year. So that's Dr. Painter's description of the situation in January of 1978, with a significant number of the haemophiliacs at the college having abnormal liver function tests, which certainly appear to be of some concern to Dr. Painter. And then if we can go to TREL 40257_044. This is another letter from Dr. Painter. This is to Dr. Winfield, a consultant haematologist in Derby, 7th of March 1978. Again, it's referring to a particular individual. We can see from the year of birth it's a child. And it says, I saw, and that's probably a reference to the parents, as they were concerned about his condition. Talking to them, it seems that they have not been put in the picture concerning the state of his liver. And this is an oversight for which I offer my most profound apologies. As you know, he is HBS antigen positive and has been so for the last 4 years. Since joining the college, his liver function tests have shown persistent abnormalities, particularly the SGOT, which has remained usually above 150 units. It is pretty certain that he does have chronic hepatitis, but it is difficult to decide without any liver biopsy if this is chronic progressive or chronic persistent. And then there's a reference in the next paragraph to liver biopsies. The general thinking is against doing liver biopsies on haemophiliacs, and at the moment we tend to observe them. If they're liable to repeated bouts of jaundice, or if their general condition deteriorates, then we consider a trial of steroids. At the moment, his clinical condition is very good, and I would not have thought that we need to consider steroids, at least in the foreseeable future. I did explain this as best I could to his parents. But I told them that one could not predict the future in these cases, particularly as it seems that haemophiliacs do not follow the usual pattern of events when it comes to chronic hepatitis. I did warn them, however, that the future might be rather grim, but that this was something that we would discuss with them more fully should circumstances change. So 3 things to draw attention to in this letter. Firstly, it is an example of Dr. Painter communicating directly with the parents of a patient. It's a third-party account of it. He's giving his account of his discussion with them to the consultant haematologist, presumably at the home haemophilia centre. But nonetheless, it does appear to record a detailed conversation with a parent, and it's one of very few examples along those lines. Secondly, we can see there the particular concern about abnormal liver function tests being expressed by Dr. Painter. But thirdly, and again relatively unusually in terms of the written material, instead of seeing hepatitis dismissed or characterised as something mild or benign or not to be concerned about, here Dr. Painter is apparently warning the patient's parents that the future might be rather grim, which would tend to suggest he regarded hepatitis as something of significant concern. There's some information in relation to hepatitis B about numbers of patients infected. Again, it's something of a snapshot, but it's at HHFT 5054. If we look at the very top of the page, it says summary diagram of Australia antigen/antibody studies, Lord Mayor Treloar College. And we can see the dates given 1970, 71, 72, 73, and then there's a box for hepatitis history. It's not very easy to show and analyse on the screen, but if we just go to the bottom left-hand corner, we can see the key to the table, which tells us that the black box is antigen detected, the diagonal lines are antibody detected, blank is negative, and then NT not tested. And then if we just go back and look at the overall picture, I think we can see, amongst other things, clearly hepatitis B at this point in time is regarded as something significant, sufficiently significant to warrant this kind of study and analysis and record being undertaken. And you can see a fair number of those in whom antibody have been detected just by looking at the pattern of results on the page, and then some in respect of whom the antigen has been detected. And then if we go to HHFT 40909, this is a communication in October of 1979 between Dr. Krask at the Public Health Laboratory Service in Colindale and Dr. Arenstam, and it talks in part about non-A, non-B hepatitis. So below the list of headings 1 to 5, it says, this is also confirmed that our screening test for hepatitis B antigen on patient on the specimens you sent us was negative. It seems, therefore, that he has contracted another attack of non-A, non-B hepatitis, as he's already known to be positive for hepatitis A antibody. He had the first attack of non-A, non-B hepatitis in 1977, following transfusion with Oxford factor 8. This is another example of a phenomenon we have observed over the past 2 years. It appears that one type of non-A, non-B hepatitis is associated with haemophil and possibly other American concentrates. The second type of short incubation of non-A, non-B hepatitis appears to be associated with transfusions of NHS concentrate or cryobulin manufactured by Immuno Limited. Since we know that Immuno acquires much of this plasma from one of the American drug companies, it appears unlikely that the association of the two types of non-A, non-B hepatitis with different products can be related to different sources of donor plasma. It appears much more likely that it's due to different methods used in the preparation of American and European concentrate. So we know that this was one of Dr. Krask's hypotheses or theories at the time. He discussed it in meetings of the Haemophilia Centre directors. But the key here really is, as well as knowing that Dr. Arenstam and others would have been absorbing this information from Dr. Krask through the regular meetings, we can see here Dr. Krask specifically writing to Dr. Arenstam, presumably about a patient under Dr. Arenstam's care, although that's a hypothesis, I think, rather than being clear, but talking about non-A, non-B hepatitis as a phenomenon observed for the preceding 2 years.
A little while back in the inquiry proceedings, I remember asking about whether anything was known of the source of the Immuno cryobulin product. Here it appears that Dr. Krask thinks that quite a lot of the pool from which it was manufactured was from United States paid donors.
That seems to be his understanding. It is a matter that we'll hopefully be reporting at the inquiry hearings in September, October, when we look at the pharmaceutical companies in more detail.
But he's got that understanding from somewhere.
Yes, I would have thought so. And then interestingly, in terms of what we know about the approach to treatment at Treloar's, Dr. Krask says this: it follows from this that it might be wise to try and maintain patients who have received only cryobilin and or NHS material in the past on one or other of these products during their stay at the Lord Mayor Treloar School. Similarly, patients who've had mainly American concentrate should be kept on these products. A high proportion of the haemophiliacs have now received all the products at present on the market, and therefore this will obviously only apply to a minority of the boys attending the school. I hope these comments will be of some help in deciding what proportions to use in the treatment of the boys. And then if we go over the page, there's reference then to being interested in receiving specimens of a particular patient's serum taken over the period of his illness. But if we go back to the bottom of the previous page, there is apparently Dr. Krask advocating a policy of keeping patients on one type of concentrate only, although he appears to think it's a policy only worth pursuing for patients who haven't already been exposed to multiple types of concentrate. And then to complete the picture in relation to Dr. Arenstam and hepatitis by the early 80s, if we go to Dr. Arenstam's thesis at TREL 40517, and if we can turn to page 72, there are several pages here about both acute and chronic hepatitis, and I think it probably is worth reading quite a lot of this so that we can see what Dr. Arenstam was writing on this topic in 1981. So under the heading acute hepatitis, he says, in this section, acute hepatitis is taken to mean a clinical syndrome characterized by jaundice, gastrointestinal symptoms and pyrexia associated with transfusions and of presumed viral etiology. It may rarely be due to type A or short incubation hepatitis. It is often due to type B hepatitis and is recognized increasingly frequently as being due to a type or types of hepatitis which are neither A nor B, so non-A, non-B hepatitis. Hepatitis, Dr. Arenstam says, has always been a risk for the patient with haemophilia who required therapy with plasma or plasma products, and we can see there he refers to publications in 1974, 5 and 7. But the risk increased markedly with the introduction of pooled concentrated preparations of factor VIII. Many of the earlier reports of transfusion-related hepatitis concerned patients who had received concentrates derived from large plasma pools. And again, we can see multiple references there, many of them older in origin. He then, in the next paragraph, talks about the introduction of cryoprecipitate. And if we pick it up, 4 lines down, it says, Davis, Grizzle and Bryan, applying maximum likelihood methods of statistical analysis, showed that glycine-precipitated AHF and fibrinogen fraction AHF prepared from large donor pools carried a higher risk than cryoprecipitate, which in turn carried a higher risk than whole plasma. And then there's a discussion about the incidence of hepatitis in patients using Swedish factor VIII. And then if we go to the next page, there's a discussion of hepatitis B. I'm not going to go through the detail of that, but it records various of the discoveries of in relation to hepatitis B. And then if we go further down the page, just picking it up before the second paragraph, we can see he refers to outbreaks of hepatitis B positive hepatitis following the use of lyophilized concentrates, emphasise this continuing problem, and there's a reference there to Dr. Krask's publication 1975. And then he says the exposure of multi-transfused patients to hepatitis B antigen is far more widespread than the incidence of acute hepatitis would lead us to suspect. Reference there to publication by Seif and Hufnagel in 1977, and to Breckenridge 1975, stating that 100% of his patients were positive for hepatitis B antibody or antigen. This high degree of exposure in the presence of routine screening is likely to be due to the use of very large pools for production of starting plasmas for concentrated preparations of factor VIII and to the concentration of the antigen in cryoprecipitates of plasma. which, apart from their use as single units for treatment, are often the starting points for the preparation of concentrates. And then we go to the next page. Sorry, there's a blank page. And then if we pick it up in the second paragraph, because exposure to hepatitis B antigen is so widespread in multi-transfused patients, the implications need to be considered in a much broader concept. And then he goes on to articulate the consequences of exposure to hepatitis B. There are a variety of responses to exposure to hepatitis B virus in human beings. A, acute hepatitis, which may resolve completely or progress to chronic hepatitis. B, asymptomatic infection with little or no liver damage, transient production of antigen development of protective features of anti-HBs. This result is obviously the ideal. Asymptomatic infection with little or no liver damage, etc. And then he refers to these patients becoming chronic carriers, so that's his third category. And then D, his fourth category, chronic hepatitis, including chronic persistent hepatitis and chronic aggressive hepatitis. Post-necrotic cirrhosis and probably primary hepatocellular carcinoma may occur as sequelae. So a clear recognition there of both the prospect of developing chronic hepatitis, including chronic aggressive hepatitis, which was regarded as the more serious of the two types so described, but then a clear recognition of the very serious consequences in terms of cirrhosis and cancer that might ensue. And then the fifth example, the fifth category is persistent production of hepatitis B viral antigen and antibody to surface and probably core antigens, and reference there to a number of disease syndromes that may result. We can see over the page, I'm not going to go through these, but he describes on the next page a number of immune complex diseases associated with hepatitis B. And then if we go to the next page, we'll see he turns his attention to non-A, non-B hepatitis. And he refers here to a number of papers, some of which we've looked at in earlier hearings. Alter et al. 1972, he there refers to, if we pick it up 4 lines down, the introduction of commercial factor VIII lyophilized concentrates was followed by at least 3 separate outbreaks of hepatitis amongst haemophilic recipients, and both hepatitis B and non-hepatitis B varieties were implicated, and 2 patients contracted both types. Reference there again to Krask, Dilling and Stern, 1975. 9 episodes of short incubation hepatitis were observed during 5 years in 6 haemophilia children after infusion of commercial factor VIII concentrates prepared by 2 different manufacturers. Cytomegalovirus, Epstein-Barr virus, and toxoplasma virus were excluded, as were hepatitis A and B. They suggested infection with 1 or more non-A, non-B hepatitis agents associated with factor VIII concentrates. One form has been called hepatitis E. Whatever the nomenclature, this form of hepatitis is as likely to progress to chronic hepatitis as the hepatitis B variety. Reference there to Spiro 78, Seif 1975, and is therefore at least as important. And then if we go over the page, there's a heading chronic hepatitis, and Dr. Arenston then has a discussion about disordered liver function tests. I'm not going to read that out, but he refers to various publications or studies in which disordered liver function tests have been reported. There is then a heading relationship to frequency and volume of transfusions. And again, the association is there described by reference to a number of reported papers. If we go to the next page, perhaps I can just pick up the top 4 lines. He refers to Minucci in 75, found that the incidence of liver function abnormalities increased with age and presumably therefore with increasing exposure to factor VIII containing preparations. There's then a heading histological abnormalities, and he says this, with the proliferation of reports detailing abnormal liver function tests, it has become increasingly important to study the relationship of the histological appearance of the liver to the chemical abnormalities in the blood. And then he refers to an understandable reluctance to undertake liver biopsy in severe haemophilia, but refers to a number of reports, including, of course, the 1978 Preston publication from Sheffield. A total of 38 biopsies were studied in these 4 series, all done on severe haemophiliacs who had persistently abnormal LFTs for at least the previous 6 months. 100% showed histological abnormality, of which 47% showed the appearance of CPH, so chronic persistent hepatitis. 34 showed CAH, chronic active or aggressive hepatitis, and 18% showed at least some progression to cirrhosis. And then this is then, I think, Dr. Arenstam's own analysis of the picture. It appears, therefore, that at present, about half of all severely affected haemophiliacs have persistently abnormal liver function tests, and more than half of these will have histological evidence of serious chronic liver disease. This bleak picture has developed in spite of the use of increasingly sophisticated screening tests for hepatitis B in donor blood. And then we pick it up a few lines from the bottom of that paragraph. He says that we also know that even if hepatitis B could be eliminated, non-A, non-B hepatitis would still be capable of inducing chronic liver damage. The addition of a further chronic disabling disease to the lot of patients already suffering from severe haemophilia is a therapeutic catastrophe and will be a major concern to those concerned with the transfusion therapy of haemophiliacs for some time to come. Might be thought to be somewhat prophetic in the way in which he describes matters in those last few lines. So that's Dr. Arenstam in his thesis in, as I say, I think 1981. That, as I say, is an overview, as it were, of some of the material relevant to knowledge of risk of hepatitis at Lord Mayor Treloar College. I'm going to turn next to the question of HIV and AIDS. I won't go to the minutes of the first Haemophilia Centre Directors meeting where the issue was discussed. It was the 13th of September 1982 meeting when Dr. Krask provided some broad information about AIDS. The relevant point to note is Dr. Arenstam was in attendance at that meeting in September 1982. He was then in attendance at the meeting in January 1983 at the London Airport Hotel, and although we have looked at it on a number of occasions, we won't necessarily have looked at it in the context of Treloar's. And so if we could go to PRSE 302647. This is one of the 2 records of the meeting that we've got, notes of meeting with Immuno at London Airport, 24th of January, and we know that's the 24th of January 1983. There is, as we've seen before, a discussion about what was regarded as potential hepatitis-reduced concentrates. And then the discussion moved on to AIDS. If we can just go to the 4th page to start with, we see in the bottom half of the page the list of attendees, and we can see there, approximately halfway down the list, that Dr. Arenstam was indeed present at that meeting on the 24th of January. And then if we go back to page 3, we have the heading almost halfway down the page, Acquired Immunodeficiency Syndrome, AIDS, and then we have the update that was provided by Dr. Krask in relation to the AIDS syndrome, what was known. He reported the cases from the US. So he was effectively updating people on the position as published in the MMWRs and elsewhere in late 1982. And then if we pick it up towards the last 2 paragraphs on the page, we can see there the update up to the 10th of December 1982, some 800 people had been reported as suffering from AIDS. There was a 45% mortality. 10 haemophiliacs in the US have been affected and 5 have died. The youngest was age 7. All cases have had prolonged treatment with factor 8, but there is no specific implication of one particular product or batch. Other cases involving blood and blood product transmission have included platelets transfused in 3 cases. In one of these cases, one of the donors was a young New York man in his 20s. A second case was a 20-month-old child with rhesus HDN who had received several units, including platelets known to have come from a homosexual donor who was asymptomatic at the time but who later died. And then we see reference to the child having developed a possible AIDS state. That's the San Francisco baby case. And I've read that out again because although we've looked at it on multiple occasions, it's important to understand that Dr. Arenstam was present and hearing this update. If we go over the page, there's reference to the incubation period for the syndrome appearing to be 6 months to 2 years, reference to so far only 1 or 2 cases having been reported in the UK. And then the next paragraph talks about precautions possibly being taken. Protocols from the United States are being considered by the Hepatitis Working Party in the UK. Apparently the American fractionation companies are very aware of the problem, undertaking some unspecified measures to screen out such donors. And then we can see the attention of the meeting being specifically drawn to those articles in the New England Journal of Medicine in January of 1983. Again, we've looked at those. The purpose here is to make clear that whether or not Dr. Arenstam had read those articles prior to this meeting, through his attendance at this meeting, he would have become aware of the position. So that's 24th of January 1983. We know then, if we go to HCDO 40411, and we go to the second page, we can see these are the draft minutes of the Reference Centre Directors meeting, 14th of February 1983. And we saw yesterday that although Dr. Arenstam was not a Reference Centre Director, he was invited to participate in Reference Centre Director meetings because of the significance of the cohort of pupils at Lord Mayor Treloar College. And we can see there Dr. Arenstam's attendance. And if we go to, first of all, to page 4, halfway down the page, we can see there's a report from Working Party Chairman, and the first report is the Hepatitis Working Party, from Dr. Krask. It looks to start with at the protocol for a prospective study of the use of hepatitis-reduced factor VIII concentrate. And then if we go to the next page, picking it up 6 lines down, we can see there the AIDS syndrome. Again, we've looked at this on a number of occasions previously, but we can see Professor Bloom referring to AIDS being discussed at the Stockholm meeting of the World Federation of Haemophilia. Reports from the US indicated that the incidence of AIDS was higher than at first thought. There was some concern that the haemophilic population of the UK who had received American concentrates might be at risk. Reference then again to Dr. Krask summarising the latest information from the US, referring to approximately 10 cases of AIDS thought to have occurred in non-haemophiliacs in London, 1 in Glasgow, 1 in Manchester, and then reference to a form for reporting of cases, and it was agreed that Dr. Krask would arrange for it to be circulated to Haemophilia Centre directors. And if we go then to HCDO 40517_001, this is the letter of the 22nd of March 1983, so sent out the month following that meeting by Dr. Krask, Dr. Ritzer and Dr. Bloom to all Haemophilia Centre directors, so it would have gone to Dr. Arenstam, and it sets out the criteria for reporting cases, it provided forms, and it contained Dr. Krask's most recent version of his paper about the AIDS syndrome. Again, we've looked at it on multiple occasions, but you'll recall it describes the plausible connection between blood products and the development of AIDS. So that's the position as at March of 1983. And of course, we know from individual medical records that it's around this time, possibly earlier, we haven't yet examined every single set of records, that the clinicians in the Haemophilia Centre at Treloar start looking for what they describe as stigmata of AIDS or signs of AIDS in Treloar's patients. And I'll come back to that in a few minutes.
I was just, as you said that, I was just looking back to see if there'd been any reference by you to such a report in January. Certainly there have been in March.
Yes. We are undertaking an analysis of the Treloar's medical records to try and work out what the time frame was in terms of those, the looking out for stigmata or signs of AIDS, and to see what the first was that we can find.
But certainly if it was earlier than this meeting, it's highly indicative of a state of knowledge.
Yes. Yes. Well, we'll report back once we've completed an analysis of all the records that we currently have. We know that Dr. Aronston didn't attend the 13th of May 1983 special meeting of Reference Centre Directors, but he would have been a recipient of HCDO 40270_004. And this is, again, a document we've looked at on numerous occasions, the 24th of June 1983 letter sent to all directors from Bloom and Ritzer, with the general recommendations, and it's the second recommendation which is perhaps of particular significance, given the cohort of patients at Treloar's, for treatment of children and mildly affected patients or patients unexposed to imported concentrates. Many directors already reserve supplies of NHS concentrates, cryoprecipitate or freeze-dried, and it would be circumspect to continue this policy. We know, of course, that was not the policy at Treloar's, and there is no evidence to suggest that at this time or in response to this letter there was any significant change of approach at Treloar's. So children continue to be treated with multiple commercial concentrates. There's no evidence to suggest any positive attempt to either revert to greater use of cryoprecipitate or to try and use more NHS concentrate. And then if we look at just a couple of examples of the kind of material we see in some of the Treloar's patient records, TREL 40108_006. We looked at a similar table in relation to one of the witnesses who gave evidence in the course of this week, in which the entry was for, I think, a date in February 1983. This is a date, the precise date is unclear. It's the 20-something, I think, of January 1983.
Yes.
And we can see there the lymphocyte and T cell results there being recorded.
So for some reason, in January of 83, those responsible for medical care at Treloar's are testing pupils for T-cell ratios.
Yes. Again, so we're undertaking an exercise to see what the earliest records of those tests being systematically carried out is. So we're looking across the range of records that we have to see what we can find, or whether there is any pattern that we can discern.
And by that time, very shortly before that time, there had been some suggestion had there in the medical press that T-cell ratios might be altered.
Yes, I'll have to check the date, but I think it's January of 1983.
Yes. Are you aware of any other reason, or those behind you, are they aware of any other reason for the testing of T-cell ratios at this stage?
No. We were discussing that over lunch, sir. No.
Thank you.
And then we can see, this next document is an extract from the records, one of the sets of records we've looked at in the course of the week. This document is not from someone whose oral evidence we've heard this week. But if we go to TREL 40267_028, so this is an extract from Lee's records, Lee Stay, who we heard from yesterday. And if we just go to page 4, just as a reminder for any who were not following yesterday's evidence, we see this entry in March of 1983, and the bottom half of the page, we can see there an indication that pupils were, by the spring of 1983, being monitored for signs which might indicate AIDS or an AIDS-related complex. Weight loss, difficulties swallowing, lymph nodes and the like. And again, we're looking to see over what period of time those kind of examinations were being undertaken and what the earliest is that we can find. And then, of course, again, as we've seen in the oral evidence this week and in the documents we've explored with individual pupils, there are then, in the course of 1983, these references to AIDS-related investigations or AIDS-related tests and references to looking for the stigmata of AIDS. The documents that we've seen to that effect, the letters are invariably letters sent to other clinicians. They're not letters sent to parents. We're trying to see what the time frame is. I should say, because I've been asked by some to what the position is, the letters, as you'll recall, some refer to AIDS-related tests or investigations being enclosed with the letter. It is not possible from the medical records that we have examined to identify what the actual enclosures were with that letter. So we don't know precisely what else was being sent to the home haemophilia centre to accompany the letter. And whether it was a table of the like we've looked at or whether it was something different, I'm afraid the records simply don't tell us at the moment. Can we then look at TREL 40239_037? Oh, no, hang on. Just check whether I've given you the right reference. Sorry, can we go to... no, that's one of the examples that we looked at in the course of the week. Could we go to TREL 40145_065, please? This is an exchange of correspondence between Professor Bloom and Dr. Arenstam in June of 83, 7th of June 83, from Professor Bloom to Dear Tony, this it just, I think it should be is just, to let you know that, patient's name redacted, had received in 1980 some of the factor 8 of the same batch as one used for our suspect AIDS patient. Although our patient may not be suffering from AIDS, I nevertheless thought that you should know. That is presumably a reference from Professor Bloom to the Cardiff AIDS patient, and we examined what information we have about his condition, his care, in an earlier presentation. But we can see here, as it were, some form of notification or alert from Professor Bloom to Dr. Arenstam about a patient, presumably a patient under Professor Bloom's care as home clinician, but who was being also treated by Dr. Arenstam as a pupil at Treloar's College.
Just as a matter of interest, this is one letter to one doctor about one patient, which refers to one batch. It's not the same batch as the one used for our suspect AIDS patients. It's as one used.
You're right.
So one imagines that the patient concerned, from the records that we looked at earlier, had a number of different batches. Did he write to every person that he knew or might have known was in receipt of such a batch?
Not that we've seen. That doesn't mean he didn't. It just means we haven't identified similar correspondence. We've located this letter because it appears in records relating to Treloar's, presumably because it concerns a patient who was both under the care of Professor Bloom and under the care of Dr. Arenstam.
I mean, it doesn't look like a template letter, because the the name Tony is actually typed as opposed to handwritten in, which might have been if it had been a template. But
and then Dr. Arenstam's reply is also instructive. It's at TREL 40145_066. It's dated the 13th of June 1983. Dear Arthur, thank you for letting me know that the patient, he has received some factor 8 from the same batch as one of your AIDS suspects. We reviewed the T-cell subsets of all our college boys earlier this year and found that 15 out of 43 had reversed ratios. He was one of these with a reversed ratio, and I enclose a summary of our results. The reversed ratio was associated with a high rather than low absolute lymphocyte count. He had, in addition, a raised IgC and some circulating immune complexes. We are repeating all this work on our boys at present and was planning to let you have all the results when the second survey had been completed. Clinically, he exhibits none of the stigmata of AIDS. He's leaving us shortly and will let you have an up-to-date summary of all our findings in the very near future. So it tells us, I think, a lot about what Dr. Arenstam was doing at Treloar's. It would appear from this fairly clear that the decision to review the T-cell ratios was a deliberate, systematic decision in response to the risk of AIDS. And it tells us both what the findings were and a plan to repeat all the same work, so some form of ongoing monitoring of the T-cell ratios. There is also, if we go to TREL 40143_058, what you might think, sir, but it's a matter for you, a somewhat telling letter in terms of its tone and content, of the 14th of June 1983, so it's the following day. It's a letter to a GP. It does not appear to be about a pupil at Treloar's, and I say that because of the year of birth that's there identified. So it would appear to be one of the adult patients who come within the haemophilia centre's catchment area. He was reviewed at our clinic today. I'm sorry to report that he's lost movement in both elbows and both shoulders. This appears to be a direct result of his reluctance to treat himself adequately because of the current hysteria about AIDS. I have explained the very small risk numerically of him acquiring the disease, but he is adamant and is, I am afraid, retreating very much into himself. So the risk of AIDS referred to in those terms by Dr. Arenstam, current hysteria. His Dr. Arenstam's view was a very small risk of a patient acquiring AIDS. And then we see set out in the next paragraph, it is worrying in this respect, as he has lost some weight, we have found a few lymph nodes, and his T lymphocytes are showing the same sort of inverted ratio that characterises the illness. We will be keeping a close watch on him. So it is a letter which simultaneously says there's a current hysteria about AIDS and a very small risk of this patient acquiring it, and then sets out in the second paragraph the very indications that might suggest that the patient has indeed acquired the illness.
Well, it appears to add further weight to the suggestion. It's not yet a fact, but the suggestion that the only reason for conducting T-cell ratio tests is because it is thought they characterize AIDS.
Yes. And if we just go to TREL 40108_033, we're still in June of 1983, we're now towards the end of June, and it's another example of the type of letters that we see being written by the Haemophilia Centre. This is from Dr. Wassoff, as a number of them were, to the Home Haemophilia Centre, with an update in relation to bleeding episodes, transfusions, prophylaxis, and so on. And then the reference under the heading AIDS-related investigations. Clinically, he exhibits none of the stigmata of AIDS, and then there's reference to a particular examination of lymph nodes undertaken on the 11th of March 83. For your information, we've undertaken the enclosed AIDS-related tests. We've repeated these tests and we'll let you have the results when they're available. And as I indicated a few moments ago, we can't trace in the records what the enclosures were and whether it's the tables of T-cell ratios or something else. And there are a number of other examples, again, from witnesses from whom we've not heard orally of letters of this kind, and we've seen also examples in earlier oral evidence of letters of this kind. There's then, if we just move into July of 83, I think one more document worth considering. It's TREL 40248_094. This is a letter from Dr. Evans at the Royal Manchester Children's Hospital, 14th of July 1983, to Dr. Arenstam. It would appear it's in response to the type of letter that we've just looked at. And it says, thank you for sending me the reports about, and then the name of patients identified. We've not seen one of them recently. I do not know what's happening to him. We've arranged to continue his injections, but we'll be discussing the AIDS implications with the family shortly, and we'll let you know what we eventually decide to do. So there is an example of a home clinician, it appears, actually proposing in July 1983 to hold a discussion with family members. And there's a postscript, a handwritten postscript, which says, we've discussed with his mother, but not yet his father, they're separated, and will probably stop the desensitisation.
That may be a reference, probably is a reference, to giving a huge dose of factor VIII regularly because of inhibitors.
Exactly. Yes, that's exactly what I think it's a reference to. And then I think the final document in relation to 1983 to look at is at HSOC 0019923_006. This is just a report of the minutes of the meeting of the Council of the Haemophilia Society, 8th of October 1983. You'll recall Professor Bloom gave an address. And if we go to the bottom of the second page, we look at the last paragraph, we can see it says, the chairman reported that Professor Bloom had given a most helpful introduction to AIDS, outlining its background and the present situation in the UK. Those present were unanimous in their appreciation to Professor Bloom, Dr. Ritzer and Dr. Arenstam for a most useful and informative session which had helped to allay many fears created by the media. So Dr. Arenstam had participated in that Haemophilia Society address in October of 1983. I'm not proposing to really go to any documents beyond October 1983 because what we've looked at amply demonstrates a state of knowledge throughout the course of 1983. There is no evidence that we have yet discerned in either the documentation that has been analysed or in the statements that have been received by the inquiry and indeed the oral evidence given to the inquiry of any change of approach or treatment policy or any particular response to the risk of AIDS on the part of Treloar's Haemophilia Centre other than the process of monitoring that we see reflected in those records and those clinical communications. The return data and other data we have indicates that commercial concentrates were still used in large measure. There's no evidence of any attempt to adhere to a single brand or limit exposure to batches. There's no obvious evidence of any reduction in terms of the volume of product used.
Well, quite the opposite. In 1984, there was the highest single
Yes.
year for
Yes.
use of concentrate.
And as far as we can see from the individual medical records, the approach to prophylaxis continues in 1983, 1984. And it's really only when one gets the switch to heat-treated concentrates that one comes across any particular, any change of position. There is some evidence, we've seen it in I think, some of the oral evidence this week, of a trial, a limited trial in 1983 of a heat-treated product for one patient. And there's also some evidence of participation by Treloar's pupils in a trial of a Lister heat-treated product in the autumn of 1984. But the switch to heat-treated products for all appears to be essentially from the end of 1984 and early 1985, as indeed is fairly common in relation to other centres as well. In terms of the process of testing patients or pupils at Treloar's for HTLV3 once a test was available, we've looked already at those letters with that rather curious wording which refers to tests being undertaken in early 1984, but which in all likelihood we think must be a reference to retrospective testing on stored samples. We can see if we go to TREL 4 zeros, 313_133, and this is a letter from the 27th of December 1984 to a Guernsey doctor. It refers in the first paragraph to taking the opportunity of sending a blood sample to Colindale to check for the presence of antibody to HTLV3. Refers to the results being equivocal. They would wish a further sample to be sent. So that's some indication that in terms of who undertook the tests, testing was being undertaken at Colindale for some, at least, of the Treloar's pupils. And then Dr. Arenstam says this in the next paragraph: I would not like to unnecessarily alarm the mother, as the presence of this antibody occurs in almost all severe haemophiliacs. However, it's important to clarify the possibility that he might be negative, in which case it would be essential that he be treated only with heat-treated factor 8. And then there's a request to forward a sample to the Public Health Laboratory in Colindale. And then the last paragraph: incidentally, it's now pretty well accepted that haemophiliacs who are severe should be switched to heat-treated concentrate. And he expresses the hope that that will be a possibility in Guernsey. So that's Dr. Arenstam's view on the position of heat-treated concentrates at the end of 1984. And of course that follows the meeting in Elstree on the 10th of December 1984, at which the AIDS advisory guidance was drawn up. So there are then just, I think, two further pieces of information wanted to refer to, and then I'm proposing to play a documentary, and that'll sort of, I think, take us to a convenient end for the afternoon. The information is about numbers of patients infected with HIV through treatment at the Treloar Centre. If we go to HHFT 301073, please. We looked at this, I think, at an earlier stage because of what it said about the use of concentrates. We can see it's a report to the region. It's from, I think, 1986. I can't now find the precise date. But in any event, I may come back to this for other purposes tomorrow, but if we look at the heading AIDS HIV, It says this problem has overshadowed all other aspects of haemophilia care over the past few years and will continue to do so. I feel that the region should be aware of the impact on its regional haemophilia centre and make no apologies for the detail of this presentation. 43 of our patients are HIV antibody positive. Retrospective sampling has made it possible to estimate the year of infection in 33 patients, 2 seroconverted in 1980, 5 in 1981, 10 in 1982, 11 in 1983, and 5 in 1984. The remaining 10 have all been seropositive for at least 3 years. We don't have any of the underlying documentation in relation to that process of retrospective sampling. Maybe it was held in Colindale, I know not. But we only have this, which reports 43 patients antibody positive, and those may not be all pupils of the college. They may relate to some within the wider catchment area of the centre. Again, it's not clear. If we then look at the recent data provided provisionally by UKHCDO, it's at INQY 40250. And if we go to the second page, please. Bottom of the page, Centre 35, Basingstoke and Treloar's, gives a total of 61 cases. And we can see there the years. So 1 recorded for 1984 for 81, 8 for 82, 16 for 83, 13 for 84, 19 for 85, none for 86, 87 or 88. Now, that whether that is referring only to the Treloar's haemophilia centre or captures any wider data, we're not clear about, but that is the centre number for this haemophilia centre. And so what the significance of the differences between that data of 61 patients and the 43 patients being reported in 1986 by Dr. Arenstam is unclear. So, as I say, I want to come back to Dr. Arenstam's report in more detail, but I'll do that tomorrow. For present purposes, what I propose we do is we play the documentary.
Well, I think before we do that, we ought to give people a break for the usual reasons in the middle of the afternoon. If I may suggest a quarter of an hour, I hope that gives those of you who need a break long enough to use it properly. So a quarter of an hour, we'll be back at 10 to 4.
Thank you, sir.